Good evening, everyone. Thanks for joining the 28th webinar in the series of webinars from AOC in India this year. And this is the fourth webinar for the epilepsy SIGs. As you all are aware that we have divided various SIGs, and this month is the SIGs of Epilepsy Month. But it's not that the SIGs are coming only for Wednesday webinars, but they will be having their own series and courses, which will be shared with you. And wanted to also apprise you that we are very grateful to the support provided by the attendees from across 40 countries in the last 27 webinars. So that is really it's very, very grateful to all of you for joining, and it's very reassuring. And we have also been recording all of them, and we made an AOC in India YouTube channel so that it can be used and shared again. And all the videos, if they are if you have not been morphed, they will be morphed before being uploading on the YouTube. So that is there. So I introduce this session. Dr. Mahesh is busy in some personal issue. We'll have 4 cases this time for epilepsy surgery related cases, and the experts, as we have always decided to have experts from diverse backgrounds, diverse resources, resource constrained, well-resourced countries, and adult neurologists, pediatric neurologists, and also that you have a better brainstorming and understanding. So we're grateful to Dr. Ahmed Ritauddin bin Mohammed, who's consultant pediatric neurologist, Hospital Tunku Aziza, Kuala Lumpur, who's been graduated from University College of London in 1997 and is member of Royal College of Pediatrics and Child Health UK 2003. He's received his training in pediatric neurology and epilepsy at the Hospital Kuala Lumpur and Royal Children's Hospital, Melbourne. He heads the pediatric neurology unit in Hospital Tunku Aziza, Kuala Lumpur, and is actively involved in training and research. Thank you, Dr. Ahmed, for joining. I know it is late night for you. Thank you so much. And then we have Professor Dr. Suresh Pujar, who has Indian origins, but right now is lucky to be in a well-resourced country. He's consultant pediatric neurologist at Great Ormond Street Hospital for Children, London, UK. He's honorary lecturer at the University College of London and chair for the British Pediatric Epilepsy Group. He's chair of the UK Pediatric Epilepsy Program Board. And his status, epilepticus, fires, Rasmussen, complex epilepsies, epilepsy surgery, ketogenic diet, and transitional care are his areas of interest. We are very grateful for him to have joined, and we are grateful to Dr. Dinesh Nayak, who is Director, Department of Neurology and Advanced Center for Epilepsy, Glengale's Global Health City, Chennai, who is an adult neurologist with areas of interest of epilepsy and intracranial EEGs. He set up a level 4 epilepsy surgery center at Chennai and Bangalore, over 400 epilepsy surgeries in last 13 years, and actively involved in conducting teaching sessions of the Nissan EEG workshops. He's got very high claims and medals and awards, even a award from the King College London, and has over 50 publications and 10 chapters. Thank you all for joining. Today's sessions will be moderated by Dr. Lakshmi Narayan and Dr. Ranjit, both of them being my alumni. Dr. Lakshmi Narayan is currently senior consultant epileptologist and pediatric neurologist in the Advanced Center for Epilepsy, Glengale's Global City, Chennai. He's our alumni, as I told you, and his areas of interest are complex pediatric epilepsies and epilepsy surgery, and he is member of ILA Pediatric Epilepsy Surgery Task Force and ILA Epilepsome Task Force, and national convener of the Young Epilepsy Section of the IES. Dr. Ranjit is younger to him, and he left us more recently than Lakshmi, and he's associate professor, consultant pediatric neurologist and epileptologist at Chennai, and he's just finished his training in the SIG Kids and in pediatric epilepsy, and he's received the prestigious Johnstone Medal for the best outcome student of MMC, and also got the best fellow award in SIG Kids. Thank you, both of you. And for the timekeeping, Ranjit will be keeping the time for all, and Lakshmi will be keeping the time for Ranjit. So we have planned 10 minutes for the case presentations, 5 minutes for the discussion. So there are 4 cases in all. If anybody is presenting 2 cases, be sure that you finish in 10 minutes. The idea is priming everyone, and then discussion between an adult neurologist and we have our pediatric neurologist from various countries to discuss on that. And then in the last 30 minutes of today's session, we are going to have a rapid quiz in which you're going to have 30 questions. And the prize winner number one is going to get free registration of the conference and the workshop of the AOC and annual conference coming. The registration fee is 8,000 and workshop conference registered fee is 5,000. So it becomes 13,000. And the second prize one will have only the conference registration waiver. And the third one will have a workshop waiver. So I think all the best to all of you to join also the quiz, and you're welcome to that. Now I hand over the floor to Lakshmi and Ranjit.
A very good evening, everyone. Welcome you all to this exciting session. As we all know, about 70% of pediatric epilepsies can be controlled with the medications alone. But still, even after many newer anti-epileptic medications, up to 25-30% of patients are drug resistant. In this population, if you see, majority of them are structural epilepsies or genetic epilepsies. In the structural epilepsy, most of them can be evaluated for epilepsy surgery. The crux of this epilepsy surgery program is the selection of the patient, right patient for the right surgical procedure. So that's what we are going to demonstrate in the following 4 cases. For the pre-surgical workup, we give importance to 3 most important things: the clinical evaluation, the video EEG, electroclinical correlation, and the neuroimaging. With these, most of the times we'll be able to select the right patient for the right procedure. I'm proud to state that the epilepsy surgery in India has evolved leaps and bounds and tremendously in the last couple of decades, including the pediatric epilepsy surgery, that we are able to do most of the most difficult cases of MRI negative epilepsy, including stereo EEG in the pediatric age group, that we were not able to do, say, 10 years ago. So with that introduction, I will start the first case. I would like to invite Dr. Minnie Susan Abraham, who is a postdoctoral epilepsy fellow with us in the Advanced Center of Epilepsy at Gleneagles Global Health City, Chennai, to present her first case.
Thank you, sir. Sir, my screen.
Yeah, please put the slideshow, please. Yeah, please start.
Good evening, everyone. Today, I will be presenting a difficult case of an MRI negative epilepsy, which was extensively worked up, and it's a long case. I'll try to present very briefly. My patient is a 10-year-old girl. Her perinatal history and development history was normal, and her birth weight was around 3 kg. There was no history of any antecedents or febrile seizures in the past. The first episode of unprovoked seizure was at the age of 3 years, that is in 2016, and she was evaluated at the age of 3 years itself. And the semiology was there was the sudden arousal from sleep. She will be looking confused, unresponsive, and restless, and there was excessive salivation. At times, she stands on the bed, trying to get out of bed, sometimes clenching of teeth noted. And all episodes started 5 to 10 minutes after the sleep onset. And there was no tonic posturing or clonic movements, and there was no history of any status epilepticus. The initial frequency was once a day initially and gradually increased to several times at night, 10 to 12 episodes in next 2 to 3 weeks. And on examination, there was no focal deficits, there was no neurocutaneous markers, or her developmental age was appropriate. And for the since it is a sleep-related hypermotor epilepsy with an explosive new onset seizures, we proceeded with video EEG for precise electroclinical localization. And in the video EEG, we had left frontocentral slowing and left midline frontocentral slowing. And we had runs of spikes across T3, C3, and P3 and midline. And this is the event we recorded during the video EEG monitoring. In this, we can see that this is the seizures was everything was sleep-related seizures. The child was sleeping. There was an abrupt arousal, and the right foot was immobile initially, and the left foot was continuously moving, left lower limb. And then She was looking to the left side, and there was repeated to and fro movements of the left upper limb. The mother was holding her right upper limb, so we don't know the movement of the right. And there was repeated to and fro movements of the left upper limb. And she was looking to the left side. And now there was a persistent posturing of the right upper limb, dystonic posturing of the right upper limb. She was confused and she was looking towards the left side and turning some truncal version to the left side. This was her habitual seizures, and there was no verbalization or vocalization during the seizures. And this is the ictal EEG with the pre-ictal, where we can see this is sleep symptoms can be seen. This is sleep from sleep. And during the onset, there was a heralding diphasic sharp phase left hemispheric. And there is a midline ictal rhythm and diffuse ictal rhythm. But we can see that it is maximally evolved in the left frontocentral region and the midline region. Here, the left frontocentral centroparietal region and the midline region, it is a diffuse. So after the video EEG, our clinical formulation was it's a left hemispheric extratemporal hyperkinetic hypermotor seizures with elementary motor signs. With the right upper limb, there was a persistent dystonic posturing. So the possibility of a type 2 with elementary motor signs, the possibility of a type 2 hypermotor seizures was considered. And after the first visit and evaluation, we did an MRA brain epilepsy protocol, which was normal, and we started on medications. And her seizure frequency reduced, seizure free for a few weeks, and then minor episodes once or twice every few days. Then after 1 year, but her seizure frequency increased, multiple from daily seizures at night with multiple hospitalization, with behavioral and learning difficulties and some speech and language difficulties, new onset. And she was on multiple anti-seizure medications trials. So we again worked up in view of that, and we recorded the video EEG, which recorded the same stereotyped seizures with brief in duration. And the electroclinical formulation was the same, that the type 2 hypermotor seizures with the possibility of left hemispheric lateralization and localizing to the other sides like mesial frontal, anterior cingulate, parietal operculum, and the insula. So insula seizures can have frontal, temporal, and other distribution can be there. So these several localizations we considered, and we proceeded with further evaluations like serial MRIs. We didn't find much definite focal lesions in the serial MRIs. Proceeded with the PET scan, where there is a left insulotemporal, left insulo-opercular hypermetabolism. This is the picture showing left MRA PET co-registration, where you can see there is a left insulo-opercular hypermetabolism. So the patient with sleep-later seizures with MRI negative and left hemispheric. And since it's a language dominance, we have to find an exact localization, seizure onset zone, since opercular involvement is also a possibility. Exact ictal onset and language network have to be mapped. So we need proof of hypothesis with invasive EEG. And the insular opercular surgeries can have several complications due to the intricate relationship with vascular structures. So we need a stereo EEG. Stereo EEG is an invasive EEG technique where wire electrode, several contacts is implanted inside the brain through burr holes based on the hypothesis from the electroclinical localizations for mapping the language functions, for mapping the exact ictal onset zone. So we proceeded with stereo EEG, covering the left insulotemporal network, left frontal orbitofrontal, left anterior cingulate, left temporoparietal language network. These are the 13 electrodes orthogonally placed in the left hemispheric region for the workup. And this is the post-implantation MRI of all the electrodes. And we recorded the seizures and the intricately. We can see that in the anterior superior insula and the posterior superior insula, there were repeated spikes, repetitive periodic spikes across anterior superior insula medial contacts 2 and 3, and the posterior insula 3 and 4. And we recorded the same stereotyped seizures during stereo EEG monitoring. And we recorded during the stereo EEG monitoring, this was the pre-ictal part of the spontaneous seizures recorded during the stereo EEG monitoring, where we can see that the intrictal activities, the background and everything we can see. But at this point of time, there was a diffuse attenuation, and we can see that there is a slow waves, which is on the anterior superior insular regions and anterior insula, and this is where the clinical onset happens, and we can see that after these diacetic slow waves, there is a fast activity across anterior superior insula 2 and 3 electrodes, medial contact 2 and 3 electrodes, and there are fast spikes, which is evolving into the entire regions afterwards. So, and so spontaneous seizures, we have anterior superior insula 2 and 3 possible onset, and when we stimulated, we got seizures from anterior superior insula at 1 milliamp current and from posterior superior insula at 3 milliamp current. So possible sites were the anterior superior insula and posterior superior insula. These are the seizure onset zones we considered. And we marked the language network to the frontal operculum and to that, then Heschel's gyrus, Wernicke's area, and the angular gyrus. So after mapping the language areas and the ictal onset zone, we proceeded with the left frontotemporal craniotomy and transopercular resection of the left insula in May 21, 2022. And this is the MRA obtained MRA after the recession of the left posterior superior insula after the recession. And after that, the patient became seizure free. And this is the histopathological report of the specimen, where the features are suggestive of focal cortical dysplasia type 2A on the left insular region. This is the post follow-up patient MR video, where we can see that she is completely seizure free. There's a subtle right hemiparesis, but her cognition improved, speech improved, no seizures of ASM, and she's able to do all her activities of daily living and instrumental activities of daily living by herself. Her quality of life improved.
Dr. Minit, your time is up. We wind up in.
Sir, 1 or 2 slides only, sir.
Yeah.
She's completely seizure free for 16 months. She's regularly going to school. There is there are for seizures for drug-resistant focal epilepsies, we need a systematic approach and evaluation. And anti-seizure medications alone does not achieve long-term remission in focal cortical dysplasia, and surgical cure is possible. Stereo EEG exploration and proof of concept needed in case of MRI negative eloquent cortex epilepsies. And when performed by experienced surgeon, there will be no permanent deficit in insular surgery. Let me conclude for the time being. Thank you.
So basically, this is a very difficult case. As you saw, this child has been going on for more than 6 years with multiple nightly seizures, with a very poor quality of life and affecting her cognition and speech. So finally, she was able to be cured completely. For the last 16 months, she is completely seizure-free of anti-epileptic medications. One point I would like to highlight here is she had dysphasia, language difficulty initially postoperatively for the first 1 or 2 months. And the video which we showed postoperatively was on day 40 of postoperative period. So all these deficits completely improved in the 2 months time. And currently she doesn't have any neurological deficits at all. She's completely intact and normal. So I would like to invite the experts for your thoughts and comments about this left insula focal cortical dysplasia and surgery, please. Dr. Suresh, Dr. Ahmed.
Dr.
Thank you,
Nayak
that's
is
it.
part of the team, so Dr. Nayak won't be speaking. Right?
I won't.
don't know. No, but you can tell about the case, na? You want to add something to what Lakshmi said, Dr.
First,
Nayak?
we will hear about the other experts, what they are thinking, then sir will add.
Okay. Dr. Suresh.
Yeah, it's a very interesting case, isn't it? And the semiology is very interesting. So looking at making a SEEG hypothesis, I think it was the exploration was appropriate considering the semiology and the EEG findings. I think, well, and in the end, the child is seizure free. That's the most important thing. So everything has been done appropriately. I'm just kind of thinking about what we might have done slightly differently. That's down to kind of availability of resources, I suppose. I mean, we do, if there is a very focal onset on SEG, we do radio frequency thermocoagulation as a proof of concept, just to kind of see whether you get any, even if it is a temporary improvement in seizures, that is just more of proof of concept type of thing. Usually they end up requiring some other form of surgery afterwards. And given there is about 10 to 20% risk of with this type of insular surgery of having any permanent deficit, our surgeons, we have laser thermoablation available at our center. So increasingly for insular lesions, we tend to do laser ablation rather than open surgery. But I mean, yes, it comes down to availability of resources. So, but yeah, nothing else to add. I think it was excellently kind of investigated and good outcome. So well done.
Thank you. Ahmed, would you like to?
Yeah, well done. As you were presenting the case, I was thinking along the lines of possibly the bottom of sulcus dysplasia somewhere in the frontal lobe, because she's got that kind of story, fairly explosive onset, multiple daily seizures. She's got fairly impressive interictal discharges. I don't see a lot of insular epilepsies. I don't know whether that's a feature of insula. I would have thought, you don't get prominent interictal discharges, just given that insula is quite deep down. So I was thinking along those lines, but yeah, I think you must have gone through a lot more thinking as you were working this girl up, and there were probably other things that make you think this is more insular rather than elsewhere in the frontal region. But well done.
Dr. Nayak,
Lakshmi?
would you like to?
No, before that, Lakshmi, there's a question. Puneet has written something. He's asked something.
Yes, ma'am. Yes, ma'am. I'll come to that. So basically, Dr. Puneet has asked whether you have performed ictal specs that could have guided the implantation of the stereo electrodes a little bit better. Yeah, we do have availability of ictal spec, but in this particular patient, we didn't think that would add anything more, because the focal hypometabolism in the PET scan, interictal PET scan itself was so remarkably marked to the degree of A metabolism in the whole of insula, along with frontotemporal operculum. So that is where, and it was matching exactly with all the semiology. So we didn't think that would have added more. Yeah, it would have been done, yes. Dr. Naik, sir?
Yeah, I think that's a very good. I mean, we have worked up this child for quite some time, and then, a lot of thought process had gone in. Commenting on, the left insula is always a very tough area. Insula itself is a very tough area. And that's the first point, a lot of risk. But at the same time, the other point is that whether insular seizures, with this kind of hypomotor HMS type 2, that is where, you have a focal motor component as well as the hypomotor component. That can come from the premotor, anterior posterior prefrontal region. It could also come from, behind, from the parietal or from the occipital to go into that region, or it could come from the insula. So every time we see a HMS type 2, we should have a broad, understanding as to, it could come from 3 different sources. HMS type 1 would have a more restricted it could come from the temporal pole or from the anterior insula. Whereas HMS type 2 usually comes from either the anterior or the posterior insula, or from the frontal, premotor, posterior prefrontal, or it could come from the parietal, from behind. So if you have these concepts very clearly, and then you see these interictal discharges which are across the sylvian, then you know that, okay, you're dealing with something which is, across the sylvian and quite deep. So these, and then with that focal hypometabolism that you saw very clearly punched out, we felt that, any further, testing. You see, in our country, we'll have to be also careful about, the amount of the money that a person can spend for each of these investigations. So, we have kind of mastered the art of, trying to use, 3 or 4 important, investigations to be able to clinch an area of importance and an area of suspicion, and then get into that. And I think we have been pretty, successful with that kind of an approach. So that's something that we have learned over the years. I mean, this is a very practical point. I mean, we can always, do many more tests, but I think the point is that if you are very careful with your clinical, electrophysiological, a good quality neuroimaging, structural, and a good quality functional imaging, I think much of even the so-called MR negative or MR doubtful epilepsies can be cracked. And I think that's the message that we wanted to spread. The other thing is about the risk of insular epilepsies. And I think, yeah, that's very important. I think it's center specific and surgeon specific. And fortunately, in our hands, we have, had only very temporary deficits. We definitely tell these patients that, you would go through a period where, you have some kind of a minor deficit. But I mean, we have now done about 20 insular surgeries, and none of them has had a permanent deficit. And that shows quite a lot of, the kind of, we make a very tiny opercular window. So that's through the in between the language areas, and then enter into the insula and then resect that part of the insula. You could, of course, definitely do a laser ablation. We don't have laser at the moment here, but we do radio frequency. We have not done it in the insula, but we have done it in some other areas, the cingulate. But yes, I mean, at some point they'll come back. And the other thing is for our patients to keep coming back. That's another thing. That's another constraint that we have. Our kind of patients would like to have a final solution, and one point and one time solution. And that's something, again, that's a challenge in our country. You can't be doing repeated interventions. Although this is a good point, we would definitely be using as a proof of concept to use radio frequency ablations to lesioning, and see whether this would improve at least for some time, and then see, and then they are willing to undergo the next major surgery or whatever it is if it's required. Sometimes it's curative also. Yeah, these are points that we have to keep in mind. We have to be open in our approach. But I think the point for the residents is that whatever be the advances in the multimodal investigative tools that we have, the most important things still remain the three basic points: very good history, good analysis of the semiology, and a good analysis of the interictal and the ictal EEG. And then you spend a lot of time on a good structural imaging and one good functional imaging. I think 80% of your problems can be sorted out. Thank you very much.
Thank you. This was an amazing case, an amazing discussion. Thank you very much. Ranjit, the second case is?
Yeah.
Mini, this will be mailed to you. Mini, the certificate will be mailed to you. Yeah.
So the second case is from Dr. Ruta and Dr. Pragya Gadgil from Mumbai.
Good evening, everyone. Today I would be presenting two cases of mesial temporal lobe sclerosis and pediatric epilepsy. Mesial temporal sclerosis leading to a mesial temporal lobe epilepsy is one of the most common substrates for epilepsy surgery in adults, and an anterior temporal lobe resection is fairly curative in these patients. However, this does not necessarily apply when it comes to pediatric patients, and we wish to present two cases of MTS in pediatric epilepsy to demonstrate the same. Case 1 is a 7.5-year-old girl second child of a non-consanguineous marriage with normal birth and development. She had seizure onset at 11 months of age in form of status epilepticus, which lasted more than 30 minutes. Her second seizure was within a few days of the first in form of focal seizures with eye deviation to the left and chewing movements with unresponsiveness lasting around 15 minutes. She had similar seizures once in 2 to 3 months initially, and she was tried on multiple anti-seizure medications for the same. There was no benefit on medication, and her seizure description when she came to us was that she always had left-sided eye deviation with chewing movements. Left hand would become tight, and her right hand would look like it is holding something or it would touch something. And then she would have jerking of the left-sided limbs. This would last around 1 minute, and then she would be out of it. Her frequency gradually increased to once in 1 to 2 weeks with a tendency to cluster. So based on the clinical semiology, we lateralized it to the right hemisphere and localized it to the temporal lobe. She came to us with an MRI, which was suggestive of right-sided hippocampal sclerosis. Case 2 is of a 13-year-old boy, second child with normal birth and development, going to a normal school. He had seizure onset at 4 years of age, initially around 1 per month. His parents could not describe the semiology, so we asked them to come back with a video. The video said that all the events were stereotypical. There was no aura or anything else. He would start with a behavioral arrest, followed by mouth automatisms, then left hand automatisms. His right upper limb would become dystonic, and it would always end in nose wiping with the left hand. Postictally, he would sway a little, but he would be amnestic to what had happened immediately before. This would happen more in wakefulness than in sleep. He never had a status epilepticus, GTC, there was never a postictal hemiparesis, and his frequency was 2 to 3 per week. So based on the semiology, we again lateralized it to the left hemisphere and localized it to the temporal lobe. His MRI was suggestive of left hippocampal sclerosis. But both these cases had some red flags for a mesial temporal lobe epilepsy. Both the seizure semiologies were never typical for MTS. None of the children, even though they had a normal development and could speak clearly, never reported an epigastric rising sensation. They had no fear. They would never go and hug their parents or anything similar. They had no reported aura before the seizure onset. They always had prolonged focal events. However, these events turning into GTC was very rare. There was very early focality in patient 1, which was less than 1 year of age, and there was no any history of febrile seizures or status for case 2, which could possibly be the cause of his MTS later on in his life. So based on these red flags, we did a pre-surgical evaluation for case 1, which showed a normal background in awake and sleep. The interictal discharges were over the right temporal, more over the anterior and the mid-temporal, but we could never pinpoint their source of origin. The ictal EEG showed a right hemispheric ictal onset. Again, we could never pinpoint which electrode it came from. The EEG spread very rapidly within 2 seconds to the entire right hemisphere and got masked with EMG artifacts. We recorded 2 seizures. The ictal EEG always preceded the clinical onset, and the semiology of both lateralized it to the right hemisphere and localized it to the temporal, possibly anterior or lateral. We couldn't say for sure. Postictal slowing was always over the right anterior and temporal electrodes, even though the entire hemisphere would become slow for a few seconds. So based on this, the MRI was done. The MRI, of course, showed a right-sided hippocampal sclerosis, but we also appreciate an asymmetric volume loss in the right temporal lobe, and there was some dilation of the right lateral ventricle and some altered signal changes in the anterior and the mid-temporal lobe. So a possibility of type 1 FCD versus Moge versus delayed myelination secondary to whatever underlying pathology there was made, but we could never pinpoint a definite cortical malformation in the temporal lobe. So a pre-surgical evaluation said that the video EEG said this was a strong possibility of right-sided lateralization with temporal onset. PET showed that there was a severe hypermetabolism, which was more significant than the hippocampal sclerosis in the right medial temporal lobe and moderate in the right lateral temporal lobe. The neuropsychology also said that this was a right hemispheric functional concerns were present. So we were sure that we were going to resect in the non-dominant temporal lobe. And a surgical strategy was made for an ATLH which extended till the hypometabolic areas in the inferior and the middle temporal gyrus. A clinical hypothesis was that this was a right temporal, could be FCD, could be Moge, or it could still be an undefined pathology. And a surgical plan was made to do a tailored resection guided by the PET hypometabolism with intraoperative ECOG findings. So pre-resection, we found that there were spikes over the inferior temporal gyrus and the temporal pole. However, no spikes were ever recorded over the hippocampus. And immediately post-resection, based on the hypometabolic areas, we saw that all the spikes had disappeared. So for the operative details of this case, the inferior resection was much more than the superior temporal resection. And now that the child is 8 months post-operative, she has never reported any concerns. And she has resumed her regular activities with regular school. Her histopathology report came back saying that this was a type 1 FCD with gliosis. Case 2, the pre-surgical evaluation again showed normal awake and sleep record. We recorded left focal discharges in sleep and awake, which were over the anterior temporal more than the mid-temporal, not sure again. But there was also an associated semi-rhythmic delta slowing. So there was a suspicion that there was an underlying structural lesion, which was the cause of his left temporal epileptogenicity. We recorded seizures in which there was low amplitude rhythmic theta over the left frontotemporal region, followed by delta activity over the entire left hemisphere. And this was majoritarily masked later on by EMG artifacts. We also see that there is an and left hemispheric slowing, again, not very sure whether anterior or lateral temporal. But the ictal EEG definitely lateralized it to the left hemisphere in the left frontotemporal region. We did an MRI. The MRI was suggestive of atrophy over the left hemisphere with white matter volume loss. There was an asymmetrical dilation of the ventricle with atrophy of the thalamus. This told us that even though the epileptogenicity was from the temporal lobe, the lesion was much more diffuse and widespread than just a temporal, and it was significantly more than the hippocampal sclerosis that the child had come to us with. So we did a PET CT and MRI.
Excuse me, you have 1 minute more. 1 minute more.
Yeah. Left temporal hypometabolism, and we knew that we had to do a tailored resection based on PET and ECOG findings. So pre-resection, we saw that there were needle-like spikes. After the anterior temporal lobe resection, we could still see this low amplitude fast activity, which all disappeared post-resection. So the resection was much more widespread than a anterior temporal resection. And post-operative 5 months, this child is also seizure-free. However, we could not find a definite structural pathology for him. So mesial temporal lobe epilepsy, when it comes to us in the first decade of life, it is very tricky, and it is usually secondary to some other primary pathology. And it is very important that we evaluate the primary pathology in detail. Otherwise, a surgical hypothesis, which is primarily based on MTLE, may lead to surgical failure in these patients if we just focus on the mesial temporal part of it. Thank you.
Thank you, Ruta. Dr. Nayak, sir, would you like to comment? Since this is a medial temporal lobe epilepsy cases, the other experts as well would like to hear from you. What are your thoughts? Dr. Suresh and Ahmed.
You want me to start? Okay, very interesting cases, and I agree. Sometimes it could be a red herring. The first case, if I remember correctly, there was hippocampal sclerosis as well, isn't it? In addition to what looked like a malformation outside of the hippocampus. I think, yeah, we would have a lot of discussion around whether to leave what looks like a pathological kind of hippocampus back, and whether removing it would probably kind of increase the chance of success following surgery. So generally we have a discussion with the surgeons around that and the benefit of leaving that, and it's kind of the risk-benefit analysis. And if a child is significantly delayed and if the hippocampus looks pathological, the chances, I feel probably we would probably go for resecting the hippocampus as well. But I mean, again, it comes down to individual cases. In this case, if they are seizure-free, then that's a great outcome for them. But you would kind of think how long is the follow-up, and what is the kind of risk that the seizures might come back. It's something to keep in mind, but it's kind of reassuring. Yeah.
We resected the hippocampus. We did a ATLH, ATL with AH in both the cases. Only thing is that the posterior margin of your resection in a standard ATL would be very conservative. You would stop even in non-dominant at about 4.5. But because the working hypothesis was that the HS is not where the seizures are coming from, and this is possibly a lateral temporal lobe epilepsy. And in both the cases, I think it turned out that the ITG was even the surgeon, during surgery said, oh, it feels different. And sure enough, the ECOG was very active there. So we tailored it to the larger hypometabolism that we saw on the PET. Otherwise, I think we would have left part of the FCD behind, very, very likely, if you would have just stuck to a standard ATL with AH. And sure enough, I'm still worried about the first patient because it says FCD1A, and you don't know how these cases would pan out in the long run, even though you've removed everything that looks abnormal on the pre-surgical.
Ahmed, do you like to?
Yeah, so I mean, in our experience, it's difficult to get a good story for auras, even in classical cases of hippocampal sclerosis in children. So I think that's not uncommon. But I think both cases showed very well that you have to worry about something else other than just pure hippocampal sclerosis, especially when you have prominent interictal discharges. In case 2, you saw very striking discharges, and you don't tend to get that in pure hippocampal sclerosis. That tends to say that there's something else over the lateral temporal cortex. So I think it was very wise that you tailored the resection rather than just doing a standard ATL.
So Dr. Nayak, sir?
Yeah, I mean, that's very nice, very nicely done. And I'm glad that, you use intra-op ECOG and you've actually done what we call as, some of the, the Australian group, especially, they call what is called a petectomy. And, and here the PET abnormality and the intraoperative acute ECOG kind of matched. Now, so, that's something interesting, because sometimes, you get more extensive PET abnormalities than what is required to be removed. So, but many times you see that, they kind of match. And I think in this case, it matched very nicely. So you had to do an inferior temporal, you had to go back quite a bit, maybe another 2-3 centimeters, I think, looking at the section.
7
And so you
centimeters.
went right up to the posterior. Yeah, so 7 centimeters from the pole, which is a very generous resection, and being on the non-dominant side, it was all right, because you don't come across the basal temporal language area, BTLA, which would have been a problem on the other side. So it's good. But supposing you had not done that, I think I'm quite certain that this child would come back sooner than later. We've had quite a bit of cases like that. So we are we believe a lot in PET and also in intraoperative ECOG. We do it in every case. It's not that we are slaves to that investigation, but why we do it on every case is that we get a lot of experience on the acute monitoring, acute recordings. We get a very good visual feel of how acute ECOG looks, and when it really is required in a case, then the chances of you making a mistake or is much less. So I think that's why we use acute ECOG quite a lot, and we do a lot of tailoring of even the standard, so-called standard ATLAH, because there's nothing standard. In every case, you see that there's something that you may have to extend a little bit. You could probably restrict a little bit and things like that. So there's nothing really standard about temporal lobectomies. We are still learning a lot about it. Thank you.
Pragna, did you consider extraoperative monitoring, especially the second patient, 13-year-old, with a lot of things against being MTS, MTLE? Like as we discussed, these two patients are very lucky to be seizure-free, and which may not be replicable in other patients. Like especially tailoring the posterior margin of the resection. How do we decide? It is very difficult on the table with the intraoperative ECOG alone. So did you consider extraoperative monitoring at some point with intracranial EEG?
What do you mean by extraoperative or video EG?
The stereo EEG or
So
subdural EEG?
because no, I didn't think of a two-stage, very honestly, for two reasons. One was that there was no question about lateralization. Then there was no question about the PET. I think, like Dr. Dinesh Naik said in the explanation for the earlier case, you're trying to be come up with a hypothesis with as less investment as possible. And there was nothing really taking me away with respect to lateralization or localization. If at all, this was a temporal plus. And then the PET hypometabolism really helped. So we did not actually think of a two-stage.
Still, we don't know the posterior extent where you have to land. Where is the posterior extent of your resection? Still, that won't be guided. Just especially on a temporal lobe.
And the ECOG can fail. I think we need to be very aware of the limitations of all these. The ECOG may not help you on a given day. It might mislead and so on. But because the PET and then the story fit in so well with the temporal. So it in so many ways both were a petectomy. But that's the other point I wanted to make with these two cases. If it's a classic MTLE, we really don't need a PET and so on. You do a video EG, you do MRI, you do neuropsych, and you get on with an ATLH. But because that history had the age of onset, the seizure type, that was all very odd. And so I think in pediatric, for residents, for pediatrics, please always say, is it more than HS? Otherwise HS is a very comforting thing in epilepsy surgery. See an HS and it's one of the.
So the message is don't just get carried away by looking at the MRI report of MTS or HS. Okay, there are more to it. So you have to really correlate concordant data clinically, electrophysiologically with because it's not uncommon to get MRI showing hippocampal sclerosis in many patients. So you have to be very careful in these kind of patients.
Absolutely.
I think we'll proceed with the third
one
case.
second. Suresh wants to say, and then we proceed with third case of Ranjit. Suresh, please. And then,
No,
Lakshmi,
just-
you monitor the time. Yeah, for Ranjit. Yeah, Suresh, please.
Out of interest, Pradnya, did they have serial MRIs? Because there was quite a lot of atrophy in the left hemisphere, isn't it? It was extratemporal as well. I'm just wondering whether this could be either a perinatal kind of insult and then they've got a hemispheric injury, or potentially Rasmussen's, which might be evolving over time.
So you're right. Most patients come to us with 3, 4, 5 MRIs done at a minimum, despite we being in a resource poor country. This was one patient who was referred by a neurosurgeon who did the first MRI at that age. So this was one who escaped through the gaps and never had an MRI done before. And the neurosurgeon sent saying, HS, do you think I can go ahead with an ATLH? But he didn't have an MRI done before. But you're right. With that, having said that, a very quick point. I think we very often, the side of the lateralization on which chronic epilepsy, refractory epilepsy has been playing along, we very often see start to see hemispheric atrophy on that side. But again, a problem with that is MTLE is thought to be a progressive condition in adults. So that's again, I think could be a red herring. If we see cortical atrophy, we do have to think of a progressive condition as well. You're right. Yeah.
Thank you so much for a wonderful discussion. And Ranjit, please start sharing the screen. And Lakshmi, please monitor the time. You're running slightly behind. Yeah.
So, do you see my screen?
Yes, Ranjit,
Yes.
please go ahead.
So, good evening, everybody. So, I will be presenting a much simpler case. It's a case of navigating the path to hope in a case of a difficult Sturge-Weber syndrome. So, this is a 1.5-year-old child, known case of Sturge-Weber syndrome, referred to us for pre-surgical evaluation. This child was first born of non-consanguineous parentage, belonging to lower middle socioeconomic status and hailing from Tamil Nadu. The history is like the child had presented with multiple unprovoked stroke-like episodes. The child would start feeling weakness on the side, that is right side, both upper limb and lower limb, upper limb and lower limb equally involved. And this weakness, in few minutes to hours, will progress to a kind of a refractory focal status involving the right hemibody. And this status would really require admission, midazolam infusion, ketamine. So this was the symptomatology. He did not report a discrete, simple kind of seizures. It was always like refractory focal status whenever he gets seizure. And started at around 8 months of age, admitted in PICU for 5 times, requiring prolonged admission. Each admission, newer anti-seizure medications would be added that will increase the pill burden, and the child would regress acquired milestones with every admission. So he has failed multiple medications in the past, like phenytoin, levetiracetam, clobazam, oxcarbazepine, and sodium valproate, and he was not on prophylactic aspirin as well. The main concern of the parents, they were very much worried and anxious about further episodes of status epilepticus, because it was causing regression and also causing huge financial constraint on the family, requiring prolonged hospital admissions and stay. So this was a picture of the child. You can see there is a port vein stain involving almost whole of the left face. And he also had subtle hemiparesis on the right side. He had early hand preference to the left, and his weight was around 13 kg. He could walk with support, cannot steadily walk on own, and waves bye-bye only to parents. He speaks only one word, amma, and vision, hearing are normal. He was always dull and apathetic in this whole period. So that would make him having moderate developmental delay. So this was a neuroimaging. I'm showing contrast images. So you can see leptomeningeal angiomatosis involving predominantly parieto-occipital, even extending up to temporal, even a little bit into the lower frontal region as well. It was like extensive involvement. And in this case, like very strangely, we noted there is a kind of enhancing cystic lesion within the body of the lateral ventricle, in the posterior one of the lateral ventricle, which is not a common finding in Sturge-Weber syndrome. And these are the SWA images showing the highlighting the blooming, indicating calcification, although we didn't have a pre-op CT showing the calcifications. And the challenge which we had in this patient was, as we all know, Sturge-Weber syndrome, the veins, the draining veins are usually dilated because of the angiomatosis, which you can nicely see the dilated centrally draining veins. This patient had a developmental venous anomaly, which is also rarely reported with Sturge-Weber syndrome, which is very close to the level of splenium. And this was posing a significant neurosurgical challenge in terms of on-table risks, including major risk of bleeding and on-table mortality. So that was a developmental venous anomaly in this patient. So interictal EEG, you can see the left parieto-occipital is attenuated when compared to the right. We can see a lot of beta artifacts secondary to clobazam and pedichloride. We can see nice spike and waves coming from the left parieto-occipital. And also another example. He also had frontal and frontopolar discharges involving the left frontal and frontocentral region, indicating more anterior anterior epileptogenic involvement as well. In this case, we didn't taper off medications. He was seizure-free at the time of admission because he always had status. We didn't proceed with the taper and trying to document an ictal video EEG because of the concern of precipitating a refractory focal status, and the parents were very much concerned with that. So we organized a multidisciplinary team meet in which we concluded it is a pharmacoresistant epilepsy causing significant impairment. Electroclinico-radiologically concordant data is there, and we didn't proceed with ASM taper and ictal video EEG. And it was surgically amenable, although with potential risks which involved, and probably leading to minimal function deficit, as he had a little bit of pre-existing subtle hemiparesis, and his age is only 1.5 years. There is a significant scope for improvement in future. So with this, we counsel the family of the various options which we usually do in Sturge-Weber syndrome, ranging from more extensive ones to more restricted ones, hemispherotomy, parieto-occipital disconnections, and focal lesionectomies. So in this case, focal lesionectomy doesn't seem to be an option. So we discuss hemispherotomy versus parieto-occipital disconnection. So the key feature in Sturge-Weber syndrome is the complete deafferentation of angiomatous areas is required for seizure-free results and improved psychomotor developmental outcome. So we proceeded with hemispherotomy in this patient. So I am, in view of time, not like discuss the benefits and risks of hemispherotomy. We all know that. This child underwent a left peri-insular functional hemispherotomy with limited resection at the level of splenium, sparing the developmental venous anomaly. So these are the post-op scans. You can see the frontobasal disconnections and temporal parieto-occipital disconnections, and you can see the tram track chunky calcifications in this post-op CT. So the neuropathology was sent from both from the brain tissue as well as from the cyst. The neuropathology of the brain tissue showed abnormal neuronal aggregates with dysmorphic neurons, vacuolated balloon cells showing specks of calcification, all indicative of Sturge-Weber like histopathology. The cyst showed cuboidal lining with wall showing loose fibromous tissue, suggestive of a benign fibrous cyst. So we also sent the brain tissue for DNA extraction and looking at the higher depth clinical exome for GNAC mutation, which is sporadic mutation which causes Sturge-Weber syndrome. In this case, we didn't pick up the genetic defect, probably because of the low level of mosaicism in the sample which could have been sent. So currently he's on follow-up at 4 months post-op. He's on 4 ASMs. We have tapered 1 ASM pre-op itself, and he's not on aspirin. So I would like to ask the experts about any role of aspirin, and his activity, alertness, and speech has significantly improved post-op. And in terms of deficits, this is he has remarkably recovered in terms of his motor deficits, and he is put on intensive neuro rehabilitation. So these are our students trying to do a systematic review on epilepsy surgery for treating Sturge-Weber syndrome. And this is our acknowledgement to our epilepsy team. Thank you very much.
Thank you, Ranjit. That is a very well managed case. Would like to get the comments from Dr. Suresh, Dr. Ahmed, and Dr. Nayak. Dr. Suresh, do you see Sturge-Weber syndrome very often, and do you use aspirin routinely?
Yeah, I mean, we have a Sturge-Weber clinic here. One of my colleagues kind of runs the clinic, and we kind of discuss all these unilateral Sturge-Weber in our epilepsy surgery meeting. And I think the case was very appropriately managed. And anyone, I mean, we can't capture seizures in these ones because they tend to have infrequent but episodes of status, and it definitely doesn't make any sense in stopping medication to kind of try and get some ictal EEG data. It's not helpful at all. So I think that I completely agree with that. With regards to aspirin, we put them on aspirin when we make the diagnosis, but we stop the aspirin after they've had the surgery. The whole point is to kind of prevent the ongoing kind of stasis of venous stasis and that causing further injury. So it doesn't make a lot of rational sense to give aspirin post-surgery. We often have this kind of debate or discussion around how far, whether TOP in this case or kind of a hemispherotomy. And I could see from the images that you showed that the motor area was involved. There was angiomatosis there, and he did have, clinically, he has weakness. So it kind of, again, is an indication that the motor area is already involved. So it made kind of sense to go for hemispherotomy. So yeah, nothing more to add on top of what you've presented very nicely. Thank you.
Ahmed?
We've not had any hemispherotomies for Sturge-Weber, luckily. We started to use prophylactic anti-epileptic and aspirin once we made the diagnosis of Sturge-Weber. It's something that we've only recently started to practice. So I think we need time to see whether that works, because there's some data to show that, you know, you get less seizures, less hemiparesis, and all these things when you use prophylactic treatment. So that's what we do now.
Nayak, sir?
Very excellently presented and excellently worked up, and the result is excellent. There's no doubt. I think less than hemispherotomy would not probably work, because already, as for reasons, you know, the hemiclonic seizures, which means that it's already, you know, the motor cortex and the sensory cortex are definitely involved. So sparing them probably would not help, and there's already evidence for that. Is there a role for sirolimus? Because there's some trials on that to kind of reduce the angiogenesis and things like that. Do you have any experience, the panelists? I've read a few case series on the use of sirolimus, and it's the halting of, or rather the slowing down of the progressive angiogenesis. What would be your take? I mean, it's just out of the out of the case. I mean, but what would you do you have any experience, especially Dr. Suresh?
No, not to my knowledge. I mean, maybe there is some experimental data. I'm not aware of any
There are some
clinical trials or any kind of clinical data coming out, but I may not be up to date with that.
Okay. Yeah, thank you. But it's a very well done case. I think it's well. I mean, hemispherotomy is probably the treatment of choice in this case. A young child, a good future. Yeah.
Thank you. Thank you.
Thank you. Thank you. I think Dr. Patil, your turn. I know we are running behind, but please start presenting.
So Zubin will present a case.
Yeah.
Yes, Zubin,
Ranjit,
go
very well
ahead.
done. Yeah, Ranjit, very well presented. And as usual, our titles are also very exotic, right?
Thank you, ma'am. Thank you. And thanks for a nice discussion. Yeah.
Yes, Zubin, please go ahead.
Good evening, everyone. Today I'm going to present a very interesting case of MR negative epilepsy under guidance of Dr. Sandeep Patil sir. So starting with, we have a 14-year-old girl born out of non-consanguineous marriage, right-handed, and she had history of seizures since last 6 years. There was no any aura. In icters, there is jerking of limbs, vocalization, some posturing and giggles, and they last for 10 to 12 seconds. At outside, she was diagnosed with JME and she was put on valproate plus Levera. But still she was having multiple daily jerks, and during presentation, her current frequency was 4 to 5 per day. She was on 3 anti-epileptic at that time, Lacosamine, valproate, and clobazam. Her birth history was normal, developmental history was normal. She was in 8th standard and average scholastic performance. There was no any focal neurological deficit on her examination. So she went under video EEG, and this was her interictal record. We can see that there is a runs of epileptiform activity, spikes and wave at FP2, F8 region. So we can very clearly see the spike wave epileptiform activity FP2, F8 anterior temporal region. So we recorded 8 to 9 seizure in 2 days. The very interesting semiology. She was in squatting position. Now she stand up. There is some picking movement from the right hand, some distal movement of bilateral upper limb. There is a smile. So jumping and some kind of rocking movement. And now she recovers. This is just 10 to 12 seconds of episodes. Another seizure that we recorded in her sleep. She gets majority of episode in her sleep. So she's sleeping. Now she has awakened, change in facial expression, bipedal automatism, some distal movement, some chewing movement. There is that smile. Now she recovers. So this is a very organized movement. We saw that she was jumping. There was no any elementary motor signs. There was smile. So according to Bonini classification, she fits into type 3. There was positive facial expressions and integrated gestural motor behavior, and that localized towards rostral cingulata and rostral ventral prefrontal regions. From this semiology, there was no clear-cut lateralization, but the localization that would be the frontal lobe. So this is our ictal EEG. In ictal EEG, we clearly see that there is fast activity at FP2, F4, then there is spiky theta followed by delta activity. So there is very clear-cut evaluation at FP2, F8 region, and also some activity at our right anterior temporal region. So that basically that was right frontotemporal. In the average montage, we can see here there is fast activity followed by spiky theta. So this is, and some activity over temporal region, but it was marked by chewing artifact. We also get some electrographic runs very clearly visible at the F4 region and also at the right temporal region. Multiple electrographic runs. This was a MRI. Basically, MRI was not very helping. It was normal. This was a PET scan, and in PET scan we clearly see that the clear-cut hypometabolism at the right anterior temporal region. There is no any hypometabolism at frontal region. And neuropsych, she was down at a visual memory task. They're pointing towards right temporal dysfunction. So to summarize, the semiology was focal seizures, that frontal origin, because the duration was short. There is clear-cut smile, facial expressions, and it is very hypermotor. But interictal, it was right temporal, MRI brain normal, PET right temporal, and neuropsych right temporal. So there is some discordant data. So what to do next? So we plan stereo EEG, and we implanted 7 to 8 electrodes. These are lateral contacts. These both are PET hypometabolic area. We cover the right middle frontal gyrus, SMA, right prefrontal, and these are the medial contacts covering the entire cingulate gyrus, plus right prefrontal, temporal, and SMA. So she got her habitual seizure while she was implanted. Similar similarity we got. When she awakens, there is some picking movement. She's constantly picking her blanket. There is some chewing, constant movement of bilateral upper limb. There is smile. And now she recovers. The episode was 10 seconds only. So the clinical onset was here, but you can see the very clear-cut activity, epileptiform activity started at the lateral context of right anterior temporal region. That is almost 6 seconds before the clinical onset. Then it spread to the right mid-temporal gyrus after 4 seconds, and the last at the clinical onset we can see the clear-cut fast activity at right prefrontal region. We also recorded one electrographic seizure. We can see that there is constant runs of epileptiform activity over right anterior temporal region, 8 to 12 electrodes. So we also get the habitual seizure during low frequency cortical stimulation originating from the right anterior temporal electrode. So that was the epileptogenic area, and this is very highly densely collaborated to the mesial frontal as well as orbitofrontal. So this was a temporal lobe origin hyperkinetic seizure manifesting as a frontal lobe seizure. So the patient underwent right ATL, and after 4 years she's seizure free. That is our histopath report, and it came out to be the Moge. Thank you.
Thank you, Zubin. So that's again very interesting case how temporal lobe epilepsy in a child can be a mimicker and can present like extratemporal epilepsy. The experts, Dr. Suresh.
Thank you, Zubin. That's a really, really interesting case and very educational. I think this is where I think semiology can sometimes be misleading in that. So semiology is, it's a manifestation of when the seizure is spread, isn't it, in this case, rather than the onset of seizures. And I'm aware of at least a handful of cases where the semiology was thought to be mesial frontal or orbitofrontal, and then upon kind of either they've had a surgery before and it's failed surgery, or you do a SEEG kind of exploration, and then you realize that it's actually anterior temporal or temporal pole where the seizures are coming from. So yeah, I mean, very nicely worked up and very nicely presented. And I think it's a very good educational case for all of us. Thank you.
Ahmed?
Yeah, I agree with Suresh. Very nice case. And I don't have much to add other than telling you a joke which you may or may not have heard before. And this is taught to me by Simon. In America, apparently they do a right temporal lobectomy first, and then they work the patient up. So if you had done that in the first instance, you would have fixed the patient. Anyway, it's
Ahmed, let's ask Canada. Puneet, you were there. Puneet?
Don't blame me. I'm just the messenger. Okay.
No. Puneet is there. Our alumni is there. Lakshmi's batchmate. He's in Canada.
I may
Puneet,
not
you are
agree
online.
with. I may not agree with that.
No, Puneet, your jokes apart. Your comments. You've been there in and out. I saw. I wanted you to speak. Then you were out. Yeah, please. Yeah.
I think amazingly managed case. I was just wondering what sampling rate do you guys use for the intracranial EEGs? Either Lakshmi or I think this case Sandeep presented.
We always use 1000 sampling rate at least. So yeah, sometimes we do 2000 also, but most of the times it is 1000. Sandeep?
Yeah, it is around 2000. 2000, I think it is 2000.
Perfect. That sounds good. Yeah, thank you.
Dr. Nayak?
Yeah, I think there's a very good example of this pseudo-frontal. This is what can be called as a pseudo-frontal epilepsy. And that's the reason why, although we kind of artificially divide these lobes into frontal and temporal, this is an excellent example of what is called a network. Epilepsy is a network. And the frontal, temporal, and parietal, and all that. We, for our understanding, we kind of divide them into different regions and lobes, and think that okay, frontal lobe epilepsy means it has to be only the frontal lobe, and temporal should be confined to the temporal. No, and so that's why the French would normally call this as a frontotemporal network. And this is the problem. So when the temporal pole has very rich connections to the frontal lobe, so it's considered as one unit. I mean, the frontal can come into the temporal can go into the frontal. So that's the reason why we always have to have a broad concept rather than have a very narrow anatomical concept. And so when you have a lesion, that's fine. I mean, that can explain. But if you don't have a lesion, you got to have a very broad idea and understanding. And this is very excellently brought out by this case. So this is a good example of a network epilepsy. I always consider networks. The frontotemporal networks, the frontoparietal networks, temporoparieto-occipital networks, network epilepsy. That's where it is. So if you have this concept, the chances of making mistakes is less. It's not eliminated altogether at all. And I don't think we can ever do that. But that's the way we have to look at it. And this is a very good example of it. Thank you.
Thank you. Thank you very much. I would just request all the panelists to just, your experts to think of a take-home message while I just ask others not to leave because we'll be having the quiz. So before I come for the take-home messages to the experts, and including our moderators, I would just request Asmita to share the conference slide and Sangeeta to explain the upcoming conference. Meanwhile, you can give one take-home message from each of your sides before Ranjit takes over as a quiz master. So Sangeeta, can you please tell about this upcoming AOC and annual conference in Vellore?
Yeah, ma'am. Good evening, everyone. Thank you, Shafali ma'am and AOC team for this wonderful webinar series in the last 4 weeks on epilepsy. On the behalf of organizing committee, I would like to invite everyone to attend the Child Neurocon 2024. The 14th annual conference of AOC in India at Vellore. Please block your dates from 8th to 10th of February 2024. We have an exciting academic schedule with 5 pre-conference workshops, including neurodevelopmental disorders, behavioral pediatrics, neuroradiology, electrophysiology, pediatric epilepsy syndromes, and pediatric sleep medicine. We also have 2 days conference with fascinating topics covering up all subspecialties of child neurology. We also have a quiz session with exciting prizes for the winners. So the conference registration link is already open in the childneurocon2024.com. The abstract submission is also open. Kindly register at the earliest and start submitting your abstracts. We are looking forward to meeting you all at Vellore. Thank you.
Thank you, Sangeeta. And the quiz which is going to come, you can stop sharing the screen, Ashmita, is going to be, the first prize will be getting the registration waiver for conference as well as the workshop. The second prize winner will get only the conference waiver. Third one will get the only workshop waiver. So now we'll request for take-home messages. I think Dr. Nayak first, please.
Thank you, ma'am. I think these 4 cases have illustrated the importance of a good electroclinico-radiological correlation. That's the first thing. The second thing is that, a particular symptom during a seizure or a sign during a seizure is just reflecting the area of involvement. It doesn't necessarily mean that it's the area of onset. So that's something very important, and that's what Dr. Suresh has highlighted just now. And it's extremely important to remember that, if you have a particular symptom as a sign or in a seizure, you must be able to understand, okay, which is the region that is producing that and what are its connections. And so that's where the network comes into the view. And therefore, if you have this particular connectomix idea or concept in your mind, then the chances of making errors is less. And then you'll also, be looking at the imaging very carefully for those putative regions which are likely to produce the same symptom. Many different regions can produce the same symptom. And that concept has to be brought into mind.
Absolutely. And clinical thing has to be the first guiding step, So when
absolutely,
clinical,
absolutely. And then, so the clinical sign and the symptom and its anatomical location where the symptom can arise from, and then that anatomical location, its connectivity to different regions. Because then you could explain it from different areas. The same symptom can be produced from different areas of connections. I think this is a very important concept that we have to keep in mind. This is my take home.
Yeah, thank you, Dr. Nayak. Suresh.
No, I mean, I can't agree more with Dr. Nayak. I think that's the most important kind of take-home message, I would say. The only other thing I want to add is having a good neuroradiologist, because you can only see what you're thinking. And if you don't provide a good clinical history and kind of details about where you think the seizures might be coming from, then it's quite likely that subtle lesions can be missed. So anyone with focal onset seizures, I would have a very high degree of suspicion, provide kind of appropriate information to the radiologist. It generally kind of helps to sit down with them and kind of say, this is my clinical hypothesis, this is what the EEG is suggesting, can we please look at this area in particular and see if we can find something for me. So yeah, in addition to the network side of things, I think it's really important to have a multidisciplinary approach, and especially if you have a PET as well, to put PET MRI together with kind of your clinical and EEG data will help you in kind of coming to finding something that might be perceptible.
Absolutely, absolutely. Ahmed and then Puneet.
I just want to thank you. I think you've got fantastic people in India. I've certainly learned lots tonight. I guess my only advice is to keep discussing cases with your colleagues, because even when you're sure that you've got the lesion, somebody somewhere may pick up things that you have missed. So you've got great people to discuss with. Thanks very much.
Puneet.
I think the experts have already highlighted the important points. I'll just say this for a mixed audience, that it's important to identify these cases who could benefit from epilepsy surgery and make the earliest referral to a place where expertise exists.
Lakshmi?
Yeah, as Puneet rightly pointed out, see, any patient with drug-resistant epilepsy should be referred earliest to a center where pre-surgical workup can be done. This is mandatory. Many guidelines point this. Early referral can lead to a cure. So we have to give them the chance. So please refer early to a center where pre-surgical workup can be obtained. Thank you.
Dr. Patil, Dr. Pradanya, one line only because the quiz is there. And Ranjit, I'm not letting you speak because you're going to speak for next 20 minutes.
I think we would echo what Lakshmi said. Refer early, refer early. Otherwise, it's a progressive condition in so many ways. So refractory epilepsy, please refer early.
Dr. Patil?
Yes, good evening all. So I agree with what speakers and experts had said, that every drug-resistant epilepsy patient should undergo evaluation. In our case, it was like treated as a JME because of shakes, and neurologist was thinking it is a JME and giving JME medicines. So in that case also, video EEG was helpful because we could look into the semiology, EEG, and find out that it was a focal epilepsy. So history, semiology, and early referral is the key. That's from my end.
Thank you. Ranjit, you can also give your message before you give your opening, your instructions for the quiz. And I would request our panelists and all, in case, you can spare next 20 minutes to stay on, but it'll be an interesting quiz. Obviously, you're not going to participate because then the others will not win. So yeah, Ranjit, please, your message and then your instructions for the quiz.
Is like,
or we might score really badly.
So I think in our setup, we are trying to do the best within the scope of so much of limitations we have for all our Indian patients. I think the scenario is slowly changing, and I'm sure we'll soon catch up. So that's my message.
Thanks. Now your message, your instructions for the quiz. Yeah.
So good evening. So this is the culmination of epilepsy SIG activity. So we had 5 sessions and extraordinary participation. So we will have a quiz now. So in which there are 2 parts. The first part is like an MCQ direct questions 25. It's through Zoom. You don't have to go to any other app. It's only on Zoom. And at the end of these 25 questions, there will be...
No, Ranjit, how will they answer it? No?
Yeah. So it will appear as a poll box. Like usually you would have done a lot of Zoom polls. Ashmita and Dr. Manasi will run the poll once I say. It will appear as a question and choices will be there. You select those choices and submit. It's like a simple MCQ.
So I will just suggest one more thing. They can rename themselves with their place also from where they are, or it's okay.
Place, and also if possible the contact number, because sometimes
contact number also. Can you please put your contact number on the in your your name should be there with your place from where you are and the contact numbers, so that we can get back to you.
So the first part,
Asmita was saying something. Thank you, Dr. Emma.
Good evening, everyone. Dr. Mansi Deshmukh here. So,
Dr. Mansi, thanks. Yeah, thanks for joining.
That's all right, ma'am. So, what Dr. Ranjit sir was just saying was that for people who are attending through your cell phone, there is an option of polls, which is like a graph of bars. You can click that and you will see the question. And for those using the laptop, the question will automatically come onto your screen once activated. So you don't have to click anywhere. It will automatically be available. There will be 15 minutes allotted for the first 25 questions. And going forward with the video questions, I would like Dr. Ranjit to clarify the timing for that.
Yeah. So the first part, 25 questions, is 15 minutes. So once the poll appears, we'll end that part at 15 minutes. And then there will be a kind of a video-based questions. So we'll run through the video. So once the video is played, I will ask Dr. Manasi to go to the question or give the poll for that question. So it depends on how much time it takes for each video. We'll play them. So I think it should be doable. So ensure that you have a good connection, and Quizmaster's decision is final. There are no negative marks. The faster you answer, you score more. Okay.
You are the quiz master, na?
Yes, ma'am. Yeah. So
we also sorry, please go ahead.
Does anyone have any questions at this stage?
You can
also
put the question in chat box. Yeah.
Yes,
Sorry.
also one
Continue.
great thing Asmita has done is that just for everyone to get acquainted with it, she has put in 2 dummy questions. So we can just run those quickly and then move to the actual quiz.
Yeah. And all participants can join, including faculty, if they want. Yeah. Okay. So can you run the dummy questions? Yeah.
Yes, just doing that. I'm hoping you can see the questions on your screen. I will request Asmita to please keep checking the chat or Q&A to answer any queries.
Yes, ma'am.
Okay, I am ending the poll here.
Ranjit, it says host and the panelists cannot vote. I think it is good.
Okay, that's
I'm ending the poll.
Of course. I meant faculty anywhere logged in can. Yes. Yeah.
Okay, so now we are beginning with the actual quiz.
so your 15 minutes time is going to start.
And your time starts now.
Those who are finishing, don't log out because you will have some video-based questions coming in the end.
And also we will have the answers before the final results of the quiz. Yeah.
To Mansi, how much time left?
About 10.5 minutes, ma'am.
Like, so 10 participants have submitted all the 25. So we'll wind up in another 5 minutes. So 5 minutes more.
Ranjit, when 2 minutes are left, you can tell so that people are ready.
3 minutes. In 3 minutes, we'll wind out the quiz. Yeah, in 3.
So you can tell 2, 1.
Yeah.
Yeah, now. Yeah.
2 minutes more. One minute more. So we'll end this in 30 seconds. Please submit. Dr. Manasi and Asmita, you can end this part. Okay, thank you. So can we go to the next part?
Yes, just
So for the participants, there will be a video and a slide, and there will be a poll question. You have to answer the poll question. Like similarly, what you have answered so far. We can play the first one. A 6-year-old having these episodes, often while coming out of a car and getting sunlight exposure, EEG showed eye closure sensitivity and photosensitivity. Can we play the video? Can you reduce the volume?
எப்படி சார் மூச்சு விடுற மாதிரி சொல்றீங்களா? கண்ணை க்ளோஸ் பண்ணிட்டு அது மாதிரி கொஞ்சம் மூச்சு விட
அந்த மாதிரி ஃபாஸ்டா பண்ணாங்களா?
இவ்வளவுலாம் ஒண்ணும் பண்ணல.
Dr. Manasi, can we reduce the volume? Volume is not required. Okay, go to the poll question. Stop the video and you can go to the poll question. Yeah. Select one of these options. So you get 20 seconds to answer this. Okay, stop the poll. Go to the next video. Yeah. Play the video. This video was contributed by Dr. Lokesh Saini from AIMS Jodhpur. Can you play the video again once more, just quickly? Okay. Yeah. So what is the drug of choice in this condition, in this baby? So the poll question has appeared. So I will just give 20 seconds to answer. Stop the poll. Yeah. Go to the next video. Can we play the video? Okay. Go to the poll question. Yeah. So you can see the additional clue there. Go to the poll question. Yeah. Identify the seizure type and treatment for this gene. Stop the poll. Probably the next one is the last question. Do we have the video first? Yeah. So look at the video of this child. So this child was started on oxcarbazepine, later developed cognitive decline and behavior issue. Show that EEG slide. Or if it's there in the poll question, we can go to the poll question. Yeah. This is how the EEG when she presented with cognitive decline and behavioral issue. Go to the poll question. Poll question. Stop the poll. Yeah. I think that's the end of the quiz.
Yes, that's the end.
Thank you. It went very well without any glitches.
Ma'am, you're muted.
While you collate the result, Dr. Mansi, Ranjit can tell the answers,
Yeah.
right?
So I will quickly go through the. Is my screen visible?
Yes.
Yes.
Maybe the participants can share the answers in the chat box now. Which of the following is associated with musicogenic epilepsy? It is anti-GAD65. Connect the figures: optic atrophy, cerebral hypoplasia, pedal edema, hypsarrhythmia. So this is acronymized as PHOS syndrome. We asked this question in the last year's quiz also. According to ACNS guideline, what is the
It was not last year. It was 3 years back.
According to ACNS, what is the maximum duration of a bird, brief, potentially ictal rhythmic discharge? The answer is 9 seconds. If it is 10 seconds, that would qualify as a seizure. So familial focal epilepsy with variable foci is associated with, I think most of you would have got it, DEB-DC5 syndrome. Which of the following gene associated with bathing epilepsy? It is like interesting as SYN1. Which of the following is known to induce Parkinsonism? It is reported as a rare side effect of sodium valproate. And this question is often asked. What is bereft shaft potential? So this is a premotor potential which is noted before the voluntary movements. And this potential will help us differentiate between tics, voluntary movement versus cortical myoclonus and other movement disorders. Federman syndrome, we discussed in our seizure mimic discussion, which is benign non-epileptic myoclonus of infancy. Which of the following is a contraindication for WADA test? The answer is persistent trigeminal artery, because if you inject the dye in that situation, it can anesthetize the brainstem and it is risky. Which of the following drug has a dual mechanism of action, which is both sodium channel as well as enhancing GABA? So this is a newer anti-seizure medication and potentially upcoming cenobamate. Giant hypothalamic hamartoma is associated with which syndrome? So this is often seen in epileptology, Pallister-Hall syndrome. So this case we discussed in our neonatal seizure epilepsy SIG. Neonate presented with refractory multifocal seizures and also had profound rigidity and the EEG showing burst suppression pattern. And these are the MRI findings. So the gene which was discussed was BRAT1 gene. Which of the following benign variant in EEG is seen in wakefulness and hyperventilation? So most of the benign variants are often seen in drowsiness, and this variant particularly is seen in wakefulness and hyperventilation. That is Shrida, can be seen sometimes in young children also. So video questions, this child has Rolandic epilepsy, oxcarbazepine resulted in ESCS. So ideal choice could be ethosuximide. This quote is from Wilder Penfield. So first person to do intracranial EEG recording and human brain mapping. According to ILAE, deja vu is classified as focal seizure with impaired awareness. Which of the following does not cause pseudolymphoma? So we all know phenytoin causes. It has been reported with ethosuximide and lamotrigine also. Sodium valproate does not cause. Cataplexy is not seen in. So type 1 Nori syndrome, Angelman can all be associated with cataplexy. It is not seen in type 2. So this child basically had eyelid myoclonia. So that sunlight exposure, it is not sunflower syndrome. This is epilepsy with eyelid myoclonia, previously called as G1 syndrome. So we all know this. This was a true story, and this movie first do no harm. So this after the launch of this movie, there was a great amount of research in ketogenic diet. So this answer is diet. So this baby has hyperexplexia. Glabular tap had a startle like excited startle. So drug of choice is clonazepam. So what is the theme of this year's Epilepsy Awareness Month? Can anybody put in the chat box? So we shared it. It is stigma. Which of the following is the precision medicine drug for KCNJ11? This is associated with the epilepsy and diabetes mellitus. The answer is sulfonylureas. Which of the following does not cause Dravet syndrome phenotype? SCN1A, SCN1B, PCDH19, all can cause such phenotype. SCN80A is the answer here. So this baby had erratic myoclonus and the gene is PNPO. So answer is erratic myoclonus and pyridoxal phosphate. And this imaging modality we discussed in our epilepsy, this thing, it is a ASL, arterial spin labeling. Which of the following is not a common target for DBS in epilepsy? Central median, anterior thalamic, pulvinar, all tried. Nucleus accumbens is not a target. Instead, it is a target commonly tried in self-injurious behavior in autism. So this is Chapo gendarme. The most likely localization is anterior cingulate. EEG is more likely to abnormal in the following setting, except, so EEG is more likely to abnormal in age less than 6 months, neurodevelopmental abnormality, complex febrile seizure in the setting of a febrile seizure. Family history of a febrile seizure alone does not increase the risk of having an EEG abnormality. So that's the end of the quiz. Hope we have results by this time. Yeah. Dr. Manasi, Asmita, do you have results?
Yeah, just 2 minutes.
Okay. Any other comments? Like
Excellent quiz, Ranjit. It is very nice. I hope people have enjoyed. I can have any comments from anybody in the audience wants to say, can put in the chat or can you raise your hand? Just been collated. While we wait for the results, Dr. Parekh, would you like to say something? Dr. Parekh, Dr. Vaishak, Dr. Lokesh.
So, good evening, everyone. That was the whole month went fantastic. It was an excellent learning, and for everyone, I'm sure everyone enjoyed it, and the experts were like they were extraordinary. Every speaker was fantastic. I enjoyed every bit of it, and I think Madam Shifali Gulati, hats off to you, and the whole team, Ranjit, Lakshmi, everybody. So it's like I really feel that the momentum is, and let's continue the good work. The quiz is like fantastic again. It's great collection of questions and everything. So that's what I have to say. And so much. Let me know if I can be of any other assistance.
Thank you. Dr. Nayak, anything about the quiz before I ask Lokesh and Vaishak and Sangeeta to say?
I think the questions were brilliant, and I think I would have failed. Many of these questions were excellent, and it was a learning experience for me. Thank you very much, ma'am. Wonderful set of questions and brilliantly done. Thank you.
My quiz master is very good, actually.
He is really good. Very nice question.
Yeah.
Very thought-provoking.
He's done it. We did a series of webinars earlier, so he was doing every week, and then we had a grand finale. So we had 16 webinars in sessions of 8 for epilepsy, and then on the last day had a grand finale. So he's used to, they were a team of 3, but this time he has done it alone.
Wonderful. Thank you, ma'am.
Which thank you, Ranjit. Actually, he's got the knack always when he was in
Congratulations.
residency.
Wonderfully done. Thank you.
Thank you, sir.
Yeah. Lokesh.
Fun.
Lokesh.
Yes, ma'am. Good evening, ma'am. Ma'am, so learned a lot today, ma'am. Very nice session today, and quiz was excellent, as well as the sessions, all the cases.
The messages are for the attendees, not for us, because they are waiting for the results to be made. That's why they're just collating, because Dr.
Yes,
Mansi and they delayed. No, they are collating it there. So I thought any
for
message
students,
for them? Yeah.
Yes, ma'am. For students, these sessions are blessings, ma'am. They are getting to know all this from experts directly. Just beautiful sessions, and from all over the world, and experts are there.
And actually, they're all being recorded, na? It's still going into an AOC and India YouTube channel, so there will be no problem.
Yes, lot of variety, ma'am. This month was excellent. Thank you.
Thank you. Thank you. Vaishak? Dr. Nayak, actually, Lakshmi Narayan, as well as Ranjit, as well as Vaishak, as well as Lokesh, as well as Sangeeta are alumni only.
Wonderful. You got a very illustrious alumni, ma'am. Trained them extremely well, and
55 of ours, because it started in 2004. Peds Neuro DM first time. So,
it's absolutely wonderful. And Dr. Lakshmi Narayan has been, we have been associated together from 2013. This is now the 11th year in progress. So it's wonderful.
Yeah, even Puneet is our alumni. Puneet
Yeah,
was there,
I know. Yes.
Yeah.
Yes, ma'am.
Vaishak? Aisha?
Yes, ma'am. The whole month was very fruitful from an epilepsy perspective, and I should say quiz was the cherry on the cake. So kudos to all members, especially Ranjit sir. And I remember during our MBA days also, he was the official quizzer of our department.
Yeah, he'll remain quizzer for us. Yeah. Thanks. Thanks. Sangeeta?
Thank you, ma'am, and also the Epilepsy SIG team for the wonderful academic sessions in the last 4 weeks. And congratulations, Ranjit, for this exciting quiz. And you have set a brilliant quiz with exciting questions. It has been a good learning exercise for every one of us. Thank you, ma'am.
Thank you. And you have to, can't you, you should invite them again, no? For your conference. Yeah. That will continue there.
With something new information, with some new
Yeah, with some new information you have not given, not the old.
more information about programs and our faculty or special.
Sure. We'll keep adding up new information every week.
Yeah. Thanks. Dr. Mansi, are you ready with the result? Dr. Mansi?
Yes, just putting up the slide, ma'am. Just a minute.
Okay, thank you.
So we still have 71 attendees waiting with bated breath for the results. So
it's 82 attendees right now. It's okay. Maybe we can have every month one quiz with the same thing for
Dr. Mansi, can we have the slide up?
Yes, just a minute, just adjust it.
So winners, please put your contact number in the chat box so that we can contact you. Sometimes, like last time, we found difficulty in contacting you. So put your name.
No, they can raise their hand and they can be upgraded to the panelist also. We can see them also, right?
Yeah, sure.
Asmita, we can have them when the names are first 3 names are there, then we can. I just hope there are no ties. You can have them as panelists, or you can open their videos and allow them to speak, whatever way you want. Is the marks?
Yeah, this is the score out of the 29 questions. And
the first is 19 out of 29?
Yes.
Okay. Dr. Aman Alwadi, that's congratulations. Are you there? Can you, Asmita, can you allow him to come on the panel? Yeah, and Dr. Indra Sheesh Chaudhary. Congratulations. And Dr. Elizabeth Thomas, congratulations. So 19, 16, and 15. That's really good. And how many total have answered all the 29, Mansi? Doctor?
We'll just check.
Yeah.
Oh,
And
everyone
yeah.
has answered all the 29 because all of them are compulsory.
No. Everyone means what's the N who submitted actually?
How many, the count, ma'am, in total, you're saying?
Yeah. Count total of those who submitted. Yeah.
Okay, I'll just.
It's okay. And can you just have Aman, Indra, Shish, and Elizabeth on the panel, and they can switch on the video. And congratulations to all, and congratulations to everybody for having participated in the wonderful quiz. We'll have another quiz next week, next month, for the stroke SIG. And can we just have them so that before everybody goes, we can just have a look at them? Have your certificates will be sent across to you, and Aman will have the
44 people, ma'am, in
okay,
total
44.
who have attempted.
Okay, have
the
applied.
test.
Okay. So
have
applied. Okay. So
Can we see Aman?
Aman,
Dr. Aman
Rashish,
Kulwani.
and Elizabeth. Yeah. He's a constant attendee. I have seen him. Is he there? He's there. He can.
Yes,
Third
Dr.
one, Elizabeth. Elizabeth. Elizabeth.
Yeah, she's just moved to the panel.
Okay. Congratulations to you. And anything slides, certificates you can share. Aman will certificates you can share. Aman will have the conference as well as the workshop registration waived off, and Indra would have conference registration waived off, and Elizabeth will have only the workshop registration waived off. Yeah, will have only congratulations. Aman, can you switch on your video? Stop sharing the screen, please. And you can slow the certificate also, Asmita, that you had the certificates. Yeah. Aman?
Yes, ma'am. Thank you, ma'am.
Yeah, hi, congratulations. This is Aman. Yeah, you've been a constant attendee, right?
Can you introduce yourselves? Where are you from? And
Sir, I'm presently doing my DM at AIMS Shikesh.
oh, great.
Okay, congratulations, Aman. Then we can have the second. Indrashish Chaudhary. Indrashish, where are you?
Dr. Indrashish, you're muted. If you can unmute yourself, please.
Can you see me, ma'am?
We can see
your mobile phone. You
yeah.
see your mobile phone, yeah.
You'll have to reverse the camera.
Yeah. Now we can. I am a second year DM resident, pediatric neurology from Amrita Institute of Medical Sciences, Kochi.
Okay, congratulations. Yeah.
My name is Indrashish Rai Chaudhary.
Yeah,
R-A-Y.
okay. वो सब करेक्ट हो जाएगा, डोंट वरी, ये सॉफ्ट फाइल है ना, they'll correct it. And एलवादी का भी रॉन्ग था, वो सब चेंज हो जाएगा, डोंट वरी, they'll change it. They were just typing it in such a great hurry na, so you're just putting it, will be corrected when they send you. Thank you. Thanks. And what about Elizabeth?
And Dr. Lokesh has a request. Please display top 10 if possible. I think
Elizabeth.
Hi, ma'am.
I think let it go, Lokesh, let it go. Elizabeth, yeah.
Ma'am, I did my DM from Trivandrum Medical College. I passed out on this March 2023.
Okay. Congratulations. Yeah.
Dr.
Thank you all.
Give your phone number, please, in the chat.
Yeah. Thank you. And congratulations. And thank you all. And we come with the stroke SIG next week, right? Thank you, everyone. Thank you, Dr. Nayak and all our panelists and all the attendees. Thank you very much. And thanks.